Welcome everyone. Purpose of today and tomorrow is going to be to cover the data interpretation portion of the PRES 3 exam. But before we begin the data interpretation, I'm going to give you an overview of the whole exam first, so the PRES level 3, just to give you more of an insight into how the exam, what to expect on the exam day, the format of the exam, and how best to obviously study for the exam. If you're doing the course, then obviously that's going to be your single best method to gain the knowledge. But I'll give you a full overview of the exam before we begin going into the data interpretation aspect of the exam. So first of all, let's begin by understanding what is the level 3. Okay, and as you probably already know by now, the level 3 or the PRES level 3 is broken down into 3 parts. You've got your communication section, you've got your interpretation, and you've got your practical skills. Now, I understand for the Dublin exam that these are broken down over 2 separate days, but the communication and practical skills will always take place on a single day, and the interpretation skills will be taking place on another day. Okay. A little bit later on in the slides, I'll talk to you about the dates and the venues and stuff, but that information would have already been given to you by the medical council. Okay. So 3 parts that they're testing: communication and interpersonal skills, interpretation skills, data interpretation, and that's what our focus will be on a little bit later today. And then the practical skills and the clinical examinations, which when I come over to Dublin, I will go into a lot more detail in regards to how that part of the exam is undertaken. Okay. So just to let you know, the practical and communication skills occurs as an OSCE exam. For those that are unfamiliar with the format of an OSCE, they come as stations, okay, in which you'll have an examiner, an actor, which is normally a simulated patient, obviously yourself, and your task. You go in, you read your task initially, you go in, you greet the examiner, and then you perform the particular task, and you move on through a circuit of different stations. You're marked by a series of different examiners, and there'll be 12 different examiners that will be assessing you on your performances in 12 separate sort of separate clinical tasks that you have to cover. And then obviously the data interpretation can be broken down into 2 different formats. Okay, the traditional format is the paper-based exam, okay? And the newer format that's only just taken place over the past year or 2 is the computer-based examination. And my job will be to talk about both of those and the differences and how both of those are marked and how you're expected to answer the questions in both formats of the data interpretation. So just to take it a step back, what disciplines are tested? So for PRES 3, everything is tested, okay? All aspects of both clinical medicine and clinical specialties are tested in your exam, and you will have in both the data interpretation and the OSCE some skills that will be tested from each one of these disciplines. So obstetrics and gynecology, pediatrics, psychiatry, surgery, medicine, and GP, and all of these will be tested. Now, it's not necessary that all of these will be tested in the data interpretation, but certainly when you come to the OSCE exam and the clinical skills that are tested, stations will occur from at least one of these, all of these specialties, but you may get 1 or 2 from each individual one. Okay, so from obstetrics, pediatrics, etc. So these are the specialties that are tested. You don't need to go back and read, textbooks about all of these from scratch. My position is to try and teach you the relevant information that you need from each of these disciplines to be able to successfully navigate through this exam. And I will give you that by the end of, well, certainly by the end of tomorrow, you'll have a solid foundation to work on and build on for the data interpretation. But by the end of the OSCE, you will have all of these disciplines covered in their totality. Okay? Now, this is taken from the PRES 3 handbook. I would say that you don't really need to use the PRES 3 handbook now because I've summarized everything in this PowerPoint presentation for you. So you don't need to go back and read all of that again. This is what I've done for you. Okay, so I've summarized everything for you. And they've put that there's 8 domains of good medical practice. And this is essentially what the what the examiners are marking you on when it comes to, this is perhaps more relevant for the OSCE part of the exam rather than the data interpretation, because that is simply a test of one's clinical knowledge. But in the OSCE, these are the domains that you will be marked against when you're picking up your marks for the clinical skills and the communication skills. So patient safety and quality of care, that is self-explanatory. They're looking for, junior doctors that are safe to work within a medical surgical environment within Ireland. Okay, so ensuring that the data that you gather when you take a history from a patient is sufficient enough to exclude serious conditions. Okay, so that's looking at the data gathering aspect. And then the management plan that you formulate, again, is safe, so that by the time that you leave the station, the examiner feels that this doctor has safely managed that patient and ensured the highest quality of care in accordance with the best practice in Ireland. And I know that Ireland follows a lot of the UK guidelines. So I work in the UK, I work as a GP in the UK. So I'm very familiar with all of the aspects of the NICE guidance. And I will give you the relevant parts of the NICE guidance that you will need in order to pass the OSCE exam. Relating to patients is ensuring that you work in collaboration with a patient. So a lot of the, and I don't say this from a place of experience, but doctors who work in countries outside of, sort of, let's say, Europe or North America, the approach that is often taken, I certainly can say for countries like India and Pakistan, that the approach that a doctor takes when handling a consultation is a paternalistic approach, which means that the doctor is the one that is fine. They're taking the history, they're coming up with a diagnosis, but they're not involving the patient in the management plan. They're saying that this is what you need to take, and there's no involvement of that patient within their own management plan. And relating to patients and is looking at your incorporation of that patient into their own care. So do you ask the patient what they might consider what would be causing their symptoms? Okay? Do they have anything that they're concerned about? Do they have any expectations whilst coming to you to see you, if you're working in general practice? So involving patients in their own care, asking their opinion about diagnosis, about management, although that may seem strange because you're the doctor, that is one key aspect that they'll be marking you on when it comes to the OSCE exam. How you navigate through that, again, when we do the practical and clinical skills part of the exam, I will talk you through that. Communication and interpersonal skills, again, is quite self-explanatory. This is not only looking at your spoken English, and you don't have to have the best English in the world to be able to pass the exam. Obviously, you've got simulated actors. These are all of Irish descent, so they have to be able to understand your accent. They have to be able to understand the words that are coming out of your mouth. Okay. So communication, is important. It's not just spoken English, but it's the words that you use. So, for example, if you're going to explain a investigation, if you're going to explain a management, explain a diagnosis, are you doing it in a manner in which the patient fully understands before you leave that station? Okay. And interpersonal skills is a little bit similar to relating to patients. Again, it's about building rapport with the patient through the consultation, and the examiner will critique this, how you build up that rapport. Okay. And then obviously involving that patient as much as you can in their management. Collaboration and teamwork is tested a little less in PRES 3. Okay, so this is where you have tasks where you're dealing with other members of staff, other colleagues. They do come up. Okay, for example, in the emergency scenarios, and you're guaranteed in the OSCE to have at least one or two scenarios in which you have to tackle an emergency situation. For example, anaphylaxis, asthma, COPD, acute coronary syndrome, and your collaboration and teamwork will come through with the examiner. Okay? So once you do your ABCD assessment, you turn to the examiner as a senior colleague and you discuss your initial management plan and your initial workup with the senior colleague. So that's the way teamwork will be assessed in your exam. Sometimes you may have telephone consultations where, again, you have a patient who has become unwell on a medical or surgical ward, and you have to try and formulate a management plan for the patient given the information that you have on your task, and you have to discuss that over the telephone with a senior colleague and ask them to come and help you manage that patient. But again, all the specific stations that come within all of these skills, I'm going to talk to you about, particularly when we do the OSCE portion of the exam. Clinical management of all of these 8 domains is the part in which candidates score the lowest on in the OSCE. Okay, clinical management has to be according to the NICE guidance, okay, and it has to be best practice within Ireland. Now, this is slightly unusual because none of you work in Ireland, or certainly not in the capacity of a medical clinician. So for you to know the management of conditions in Ireland is, slightly strange, but unfortunately, because you're coming into that Irish system, they expect you to have the basic, safe, appropriate management of various conditions to be able to work within the Irish healthcare system. Next. Scholarship is just all about having enough medical knowledge to be able to safely navigate through the tasks that are in the exam. Professionalism is about your behavior during the exam. Okay, so the manner in which you speak, the manner in which you sit, okay, and essentially the way you behave during your 12 active stations is how you showed the examiner that you are a professional doctor. For example, if you're dealing with an angry patient, are you able, even if the person opposite you is getting extremely angry and is making you feel frustrated, are you able to hold your ground and behave in a manner that is deemed professional? All these scenarios we're going to look at in much more detail. Clinical skills. So you can assure yourself that you are going to get at least 2 or 3 stations in your OSCE that deal with clinical skills, okay? And these are practical procedures. For example, suturing, venipuncture, IV cannulation, ECG, catheterization, etc., etc. And there's a long list of them. And all of them I will cover with you during the OSCE. Clinical skills is something that needs absolute practice. Okay. When I bring the mannequins over to Dublin, you'll have ample time to be able to practice these. I will initially show you how to do all of the clinical skills, and then you will have a chance to be able to prepare and practice for yourselves. So these are the domains that you should, although you don't need to memorize the domains, you need to know that they exist, and that the examiners, when they're testing you, particularly during the practical skills exam, these are what they are marking you against. So just a little bit of information that you probably already have by now, okay? So as we know that there's 2 upcoming exams, there's one in Dublin and there's one in Cork. The Dublin is broken down over 2 days, the first being on Wednesday, the 8th of May, which is going to be your computer-based data interpretation. And the second on the 10th of May is going to be your OSCE exam. And they've done this before in the past, okay? Particularly the Dublin exam has been broken down over 2 days. Why they do that, I'm not sure. Maybe it's based on availability. But yeah, does that make the exam easier or harder for you? I can't say for certain, but hopefully, again, being well prepared, should make you get through quite easily for this exam. The Cork one traditionally has been, I would say, the easier of the 4 centres, so Galway, Limerick, Dublin, and Cork. Cork has traditionally been the easier of the 4 major centres for the PRES 3. Does that mean it's going to be easy this time around? Not necessarily, but I'm just saying from previous experience, Cork has been a relatively straightforward exam, whereas Dublin, and this is not to discourage those that are doing the Dublin exam, but Dublin, particularly from an OSCE perspective, has been a little bit more trickier in the past, okay? And when I say trickier, I mean the stations in which they test in your OSCE exam. And that's why at the end of this session, I will send you, and I probably already have sent you in the group, a list of stations that are likely to show up in the exam. There is a section there that is specific to Dublin, because those are things that have been tested in Dublin in the past. Okay, so it's well worth having a look at that list, because it's likely to show up from that list. Okay, so 2 exams, and I'm sure some of you are sitting the Dublin and some of you are sitting the Cork exam. So this hopefully is not relevant for any of you, okay? But you must pass the PRES 3 within 2 years from the date that you have been deemed eligible to sit the PRES 3, and you have a maximum of 3 attempts. There are exceptional circumstances. I'm not going to go into them because they will not be necessary. But what I can reassure you is that whoever has done whatever you guys are doing right now, sitting opposite me, no one, not a single candidate, has ever needed this slide. Okay, everyone has got through at some point, and I don't remember a single person since 2016, since I've been doing this, that has needed 3 attempts to be able to pass the exam. There may be 1 or 2, but I have seen hundreds of students over the past 7 to 8 years. So I will reassure you that you are definitely in the right place. Pariko said, "Could you please explain what computer-based data?" And we're coming on to that, my friend. Okay, so I'm gonna build up to that. Okay, so the level of the PRES 3 is that of a junior doctor or a senior house officer working in Ireland. So the conditions that a junior doctor will be likely facing, whether they work on a medical ward, surgical ward, in general practice, that is what the PRES level 3 is testing you on. Now, there's a massive blueprint, and I've put it on this slide for you. You're welcome to obviously go and have a look at it. I think at this stage, perhaps reading through the blueprint is probably not going to be the right thing for you to do, because there's just so much on the blueprint. It's just going to end up confusing you. Again, my task is to summarize that blueprint for you to make the exam more palatable and easier to navigate. Okay, so I've left the blueprint there for you, but I would not suggest that you go ahead at this late stage and read through everything on there. It's just not necessary. Okay, so as I've already mentioned, the exam is broken down into 2: the practical and communication skills and the interpretation skills, or data interpretation. The length of the exam is approximately 3 hours 40 minutes, the total exam. Okay? But when you go to the exam center, you will expect to be there for a lot longer than that. Okay, because there's a registration that takes place beforehand. You may be, held for a brief period of time whilst there's crossover between candidates who do data and then go over to do the OSCE. So you're going to be in the center for around 5.5 to 6 hours in total, I would say. And having spoke to candidates in the past, roughly it's been around 5.5 hours that they've been in the center. So it's quite a long day. But yeah, that's just the way it is. The practical and communication skills is of the allocated time, 2 hours and 40 minutes, and the interpretation skills, which does not change in time, is going to be 1 hour. Okay. What I would say about the exam, from an honest perspective, is that time is probably your biggest issue in this exam. And this is where really practicing, for example, doing, mock exams, or just simply going through questions and timing yourself how long you take to solve each question is going to be critical for you, because 1 hour to answer potentially 46 questions, which comes up in the computer-based exam, doesn't seem like a long time. You still have a little bit more than a minute to answer each question, but time is quite an important factor. Okay? Whereas the practical and communication skills, you have, and I say roughly 7 minutes, okay? Roughly 7 minutes per each task, okay? Because it can be a little bit less than that. And again, having spoken to candidates before in the past, there have been times where they've literally only given them 5.5 or 6 minutes to perform the task, and they've had to move on to the next station. Why they've done that, I can't answer that question for you because it's not my exam. But officially, you should have that 7 minutes to perform your task, and then your transfer time, which is 1 minute to move on to the next task. And we'll go into a little bit more detail about that. Talking about the OSCE, okay, so the practical skills broken down into 4 things that they're actually going to, realistically test you on: practical skills, clinical examinations, history taking, and communication skills. Now, there are 12 stations that they're actively going to mark you on in the OSCE. 6 of those will be history taking and communication skills. 6 of those will be practical skills and clinical examinations. Now, of those 6 that are practical and clinical examinations, how many of those are clinical examinations and how many of those are practical skills? That will vary from exam to exam. There is no set number from exam to exam from that perspective. I can't say to you that you're going to have 3 practical skills and 3 clinical examinations, because it doesn't necessarily fall into that category. But you will have 6 for definite within that, within the practical clinical aspect of the OSCE, and you're going to have 6 history taking and communication skills. And again, the number of communication versus history generally has been 3 and 3. Okay, so 3 history taking with management and 3 communications, again, with management as well. So as I mentioned, the practical and communication skills are combined into one exam. So even though they're marked separately, by the way, and I'll talk to you a little bit more about the marking in a moment, they're marked separately. So practical's marked, communication skills are marked, and you have to pass both. But they're done in one exam as an OSCE, as a circuit of stations. And the exam, as I've mentioned, will last 2 hours and 40 minutes. Now, the mix of the stations is, again, different based on venue, different based on, the exams. But 12 of those will be active stations. Those active stations are stations in which you are actively marked on. Okay? 6 of those are practical skills and communication, 6 are communication skills and history taking. Then you may have a combination of rest stations. So you may have 2, 3, or even 4 rest stations, okay, in which you sit and do nothing. I'm sure they'll offer you a glass of water or something like that just for the rest station. I don't think you can use the toilet during those times, but you essentially just have to sit, gather your thoughts, and move on to the next task when your 7 minutes are up. The preparatory stations, now only I of all the OSCEs, and I teach many different OSCEs, okay? Ireland is the only one that has this particular type of, I call it station, but it's not actually a station. A preparatory station or a preparation station is where you have a task that will influence the next task, okay? So you read the task, for example, let's say your station number 1 is a preparation station. Okay, you will have the task in station number 1, but you perform that task in station number 2. Okay, so from station number 1, you read the task and you go and perform it in station number 2. Okay, so that's what a preparation station is. And again, as I said, there'll be a mixture of these. So you might not necessarily have any preparation stations, but usually in the exam, there are at least 2 or 3 preparation stations that will move you on to the next task. Okay? Each station is around 7 minutes in duration, okay, as I've said, and you have a period of 1 minute transfer time between each station. Okay, so once you've finished your 7 minutes, you will then have 1 minute transfer time. And unfortunately, that transfer time includes moving to the next task and reading the next task. This is why I find this a little bit unfair, because 1 minute doesn't seem like a long period of time to move from one task to the other, but unfortunately that's all the time that you have. Okay, and you have to use that 1 minute to read the task in as much detail as you can. You will have a copy of the task in the next station for you to read again if you don't have enough time. But again, 1 minute doesn't seem like enough, but unfortunately, it's all the time that you have. Okay. So Tyler said, do they explain tasks clearly as if take history, do not examine the patient, etc.? Yeah. So for your task, and I will come on to this obviously in more detail during the OSCE part of the exam, but the task is very, very clear. You either take a history and discuss management. You won't need to examine in a history taking station. Similarly, if you're doing a practical skill or clinical examination, you won't need to take a history in those stations either. So fortunately for that 7 minutes, you only have to perform one particular type of skill. Okay. So if it's history, only history. If it's communication skills, only communication skills, practical skills, etc. Could you clarify if rest and preparation stations, they are 7 minutes long as well? Okay, so rest and preparation stations will be the same length of time as the active stations. And then it means you fail or you might pass. It depends on the type of skill that they're testing. Okay, so if you're doing a clinical examination, you have to finish that clinical examination in its entirety to be able to comfortably pass the exam, pass that particular station. So, for example, if you're doing a cardiovascular examination or a respiratory exam, and you don't even get to the chest, it's unlikely you're going to pass. Okay? Or if you're doing a particular clinical skill, for example, catheterization, and you don't finish that skill within the 7 minutes, it's unlikely that they're going to pass you for that station. So I would say from a practical element, it's important that you pass, that you complete the whole station, okay, within that time. And the only way you're going to be able to do that is by practicing them religiously. From a history point of view, you have to gather enough data from your history. The examiner may stop you when they feel, okay, this candidate has shown me enough of a logical way of data gathering. They've asked enough questions. Okay, then they'll ask you some questions regarding management at the end. Okay, so again, history, I would say that you need to show enough data gathering, exclude enough red flag signs to be able to pass that station. Communication skills, they mark you on what you've done with the time that's been given to you. So if you're breaking bad news, then obviously you have to break the bad news. If you haven't broke the bad news by 7 minutes, I'm not sure what you've been doing. But if you haven't done the key part of the task within the allotted time, then it's unlikely that you're going to get through. History, practical skills, clinical skills have to be done within the 7 minutes to comfortably get you through that task. Communication skills, you don't need to, and they put it in the handbook in bold as well. You're not expected to complete a discussion within 7 minutes when it comes to communication skills, and they're only going to mark you on what you've done. Is there a timer? So I believe that you're allowed to take your own watch, and I think it's encouraged to take your own watch into the exam to know how much time you've got. But there is, in the exam, there should be a warning bell when you've either got a minute left before you move on to the sort of, when you've got a minute to wrap up or 2 minutes, that you move on to the next task. And normally at that warning bell is where the examiner will stop you and start to ask you questions then to try and give you marks in terms of management of whatever skill that you've been showing. Are there any combined stations? It's not like PLAB 2 where you have to take a history, examine someone and manage them all within that time. Normally they're isolated skills that they're testing in each task, but the examiner will stop you and ask you questions. That's how it will go. So they are combined in terms of you have to take a history and discuss management, but that management is normally with the examiner. They'll have questions regarding investigations, differentials, and your ongoing management plan. Okay. So the examples of the practical skills, I mean, there are a lot of things that are tested. Okay. They range from examination of chronic stable disease. These are your traditional respiratory exam, cardiovascular exam, abdominal exam, neurological examinations, fundoscopy, otoscopy, etc. Your emergency scenarios, which are guaranteed in your exam, okay? BLS, automated external defibrillator, CPR, airway management. These come up in every single exam. Airway management, every exam tests this, okay? So there are some things that you have to know. Anaphylaxis, I think I've seen anaphylaxis in every single exam so far, okay? So that's something that you need to know. Meningitis, there are very common themes that they test in the exam that show recurrently exam in and exam out. So we'll go through all of those. Procedural skills, again, there are quite a number of different procedural skills that they test. Now, the PRES 3, if you compare it to other traditional OSCEs, they have a wider range of practical skills that they test you on. Okay, there are some of your more traditional venipuncture, cannulation, ABGs, but things like suturing, airway management, airway devices, there are some unique things to PRES 3 that you should be familiar with before you go to the exam. How to apply a neck collar, how to apply an arm sling. There's some classical PRES 3 OSCE stations, if you like, and again, I'm going to cover all of those with you. When you're reading your task, so let's say that you're stationed outside station number one, and your task is outside the cubicle or outside outside the door. You'll have hand gel that's provided. You have to ensure that you decontaminate your hands before you go in. You go in, you show the examiner your examination label. They'll take your number and your name, and then you go ahead and perform the task. Before and after touching a patient or touching a mannequin, ensure that you use the hand gel provided to ensure that your hands are decontaminated. Don't fail a station due to lack of hand hygiene. It's a very simple thing to do, but please make sure that you do that. Okay. The communication skills is going to assess your ability to obviously take a history. So this will come under the communication skills aspect of the exam. To talk about investigations, to talk about surgical procedures, to break bad news, ethical dilemmas, for example, contraception in children, discussion about DNAR, capacity assessment. So there's lots of different communication aspects of the exam that they're going to test you on. And again, when I do the online course, unfortunately, it's going to be a little bit close to the exam. Again, that's just because they only just released the exam dates, and I haven't had much time to prepare the course way in advance. But it will be a good revision just before you go to the exam about how to take a history well and how to communicate with the patient well. Arena said, so using hand gel before entering the station and seeing the examiner and the patient, then right in front of them again. So Arena, only for the clinical examinations and practical skills do you need to decontaminate your hands. For the history and communication, you don't necessarily need to do that. Okay. So communication skills are must, okay? And things like breaking bad news, ethics, definitely, okay? Ethical stations come up in every single exam, okay? Whether that's contraception counseling in young people, whether that's talking about DNAR, mental capacity assessment, dealing with an angry patient, these always show up in the exam, and I'm going to give you the approach for each one of the different types of ethical scenarios that show up. Okay. So this is taken from the PRES 3 handbook. You've probably already seen it before, but this is quite a good depiction of how the exam, how your 2 hours and 40 minutes is broken down. So let's say that you start with station number 1 and you move forward to station 2 and then station 3. If you look at station 3, it says preparation for station 4. That means that within that station 3, that's not actually a station. You have your task, and then when you read your task, your 7 minutes is up, you go into station 4 and you perform it. Okay, and so on and so forth. You'll have rest stations intermingled with active stations and preparation stations. But yeah, every exam follows the same format. There may be deviations to the number of rest and preparation stations, but the active stations remains the same at 12. Okay, that doesn't change. Now, interpretation skills. This is what today and tomorrow is essentially all about. Okay? Interpretation skills is exactly what the name suggests. Are you comfortable in interpreting data from simple tests, for example, ECGs, chest x-rays, laboratory results, arterial blood gas results, right the way through to diagnosing conditions based on images, rashes, etc. And photographs are heavily tested in data interpretation. And again, unfortunately, with the rashes, there are so many different types of rashes that they test you on. But I know where these pictures have been taken from. Okay, and I will signpost you to them. Okay, a lot of the course will contain a lot of the pictures that you're going to get on exam day, but I will signpost you as to where to find those pictures from. If you look at the HSE website and if you go through the conditions that affect the skin, a lot of the pictures are taken directly from the HSE website. Okay, but you won't necessarily need to do the digging around because I've already taken all the pictures from the HSE website from the conditions A to Z, and I've incorporated them within the course so that at least they're all in one place for you. And then you have, other things that are slightly more obscure, like, for example, pediatric growth charts and news charts and prescribing and pharmacology, drug interactions. All of these, again, unfortunately, are tested, and I'm going to try my best to go through as many different variants of questions as I can to make you confident when the exam comes. Okay. Now, the difference between the computer-based versus the written paper. Now, my understanding is that the computer exam is broken down into 46 different types of questions. And I believe the number of questions will remain the same in this exam as well. I don't think the number of questions is going to change. You have exactly 1 hour to answer those questions, and it is not in the form of single best answer. Okay? Because that's already been tested in your PRES level 2 or whatever other exams, PLAB 1, USMLE. They've already done that testing before. Okay? So they're not going to be MCQs. They're not going to be single best answer questions. They're going to be knowledge-based questions that you have to type in the answer in the box provided underneath each question. Okay? Now here is what this use bullet points rather than sentences. This is after discussion with quite a few candidates who have successfully passed the exam in the recent year or two. I've asked them, what's the best way to type in an answer? Okay, what's the best way to write an answer in the written exam? And they've always said use bullet points rather than full sentences. Okay, so rather than writing I would manage the patient's ABC, simply writing A, B, C, D, E would be good enough for you, depending on what the task is, obviously. Okay? So use short words, bullet points, rather than whole sentences, because you're going to use up too much time. Most of them, questions, should only require 1 or 2 words, for example, just the diagnosis or just the management. They shouldn't require too many words to be written under each question. There is no negative marking, so that means that whatever you write won't be critiqued negatively. Okay? But yeah, try and answer everything. Try and at least go through all of the questions at least once. Okay? If there's a question that you find that's a little bit more difficult, move on to the next question, then come back at the end. Okay? So for the computer-based 46 questions, 1 hour to answer the questions. You type your answers under the box provided, and I would recommend using bullet points as the answers rather than writing out whole sentences. Ensure that your spelling is correct and there is no negative marking. The other thing to mention about the computer is that there may be questions that lead on to questions. So for example, question number 1 is an ECG. Okay, they give you the ECG. They ask you to either describe the electrocardiographic findings, and you have to type in those findings. So, for example, absent P waves, irregular QRS complexes for atrial fibrillation. Or they may ask you, what is the diagnosis? You type in the diagnosis. Then question number 2 will be a follow-on to the previous question. So, for example, based on the previous ECG, what is the most appropriate management? Okay? So, for example, rate control, rhythm control, cardioversion, etc., whatever your management may be. So one question may lead on to the next question, and you may have 2 or 3 questions relating to the same clinical scenario. Does the doses for treatment, are they important? That's a good question. I would say that for emergency scenarios, yes, they are critically important. Okay. For long-term conditions, which I don't think you're going to be asked to, to things for long-term conditions, the doses is less important, I would say, in that case. But for emergency, you must know the doses. And I remember recently there was an exam scenario in the OSCE about meningitis. There was an ABCDE approach. You had to do airway, breathing, circulation, disability, exposure, and at the end, the examiner had questions about meningitis, and the examiner specifically asked about doses of all the antibiotics. So from benzoyl penicillin to ceftriaxone to cefuroxime, they asked all the antibiotics and all their doses as well, which again, I find that a little bit unfair because not many people can remember these, but unfortunately, emergency drugs, antibiotic doses, you have to keep there for your exam. Okay. The written paper is the traditional data interpretation. Okay, so this has been the one that's been there since PRES 3 first began. This is the one that I originally taught in 2016, right the way through to, I would say, 2021, 2022, when the exam changed. So traditionally, there were 6 questions, and I believe Cork is a written paper, so you'll follow the same as what I'm about to tell you. You have 6 questions, and each question will have a sub-question. So, for example, they'll give you a chest X-ray, and within that chest X-ray, there'll be 4 or 5 different questions. So, for example, describe the radiographic findings. What is the most likely diagnosis? What is the management? What are the complications, etc.? So there'll be sub-questions within a question, okay? And that's how they get to, that's how you get your 20 marks, by answering as many of those sub-questions correctly as possible. So each question from 1 to 6 is marked out of 20. How many you score obviously will depend upon how many correct answers to the sub-questions that you give. Okay. And it will be a question booklet and an answer sheet, and you write directly onto the answer sheet. Okay. Any questions about the format of the exam? Anything you want to ask me about the format, or is that clear for you that there are 2 different types of exams? Which one's easier? I can't say. I can't say which one's easier. I would probably say that the computer exam is a little bit more difficult because there's more volume of questions that you have to answer. Okay, but essentially, both of them are equally as difficult. How many sub-questions are there? It depends on the question. Okay, it depends on the question. So if there are, I've seen in the past where you literally, and I believe it was in Galway or Cork, they'll give you an ECG and there'll only be 1 question following that. What's the diagnosis? Atrial fibrillation. Next question. So you may not have any sub-questions. It may just be simply what is the most likely diagnosis, and that's your 20 marks. But I would say now, having assessed the exam over the past 2 years, 2 or 3 years, I'd say, that there have always been at least 3 or 4 sub-questions for each main question. So normally there's a logical sequence to the questions. Yes. So for example, describe your findings. What are your diagnoses? What is your differential diagnosis? What are the treatment options? What are the complications? So they'll follow a logical sequence. So again, it depends on the question. It will specify whether you have to describe the anomalies on the radiograph versus what is the most likely diagnosis based on the chest X-ray. So it depends. Okay. So if they ask you to describe the findings, for example, let's say there's a pleural effusion. I mean, it's a little bit more difficult to describe in that case because pleural effusion is a pleural effusion. But they will either say describe the findings or come up with a diagnosis. And I'm going to look at chest X-rays in a lot of detail with you. Okay. So we'll look at the different variants of chest X-rays a little bit later today. Okay. What about if you get the diagnosis wrong on the written exam? Does it mean the remaining answers will be wrong? Well, how to answer that question? The sub-questions are there for a reason, okay? If you get one sub-question wrong, it doesn't mean that you've necessarily failed the question, because you may get the other parts of the questions completely correct. But I would say that if you're getting the diagnosis wrong, that means your thinking is in a different way about whatever the condition, the clinical scenario, ECG, chest X-rays, and that means your management is invariably going to be wrong. So if your diagnosis is incorrect, it's likely that you're not going to pass that particular question. So if answer to first question is incorrect, then the answer to sub questions will automatically be incorrect. I mean, if diagnosis is incorrect, then the rest, yeah, absolutely. If you don't know the diagnosis, of course the management is going to be incorrect. So yes, more likely going to get the question wrong. Is that each question is weighted differently we're talking about now the computer-based exam. On the sheet of paper that they give you beforehand and the breakdown of the mark, each particular type of interpretation skill, they're weighted differently. So what you're saying is you should answer the questions that are weighted more heavily first rather than the ones that have got. But again, I think for the computer versus, for the computer exam, I would still probably go in order so as to not try and waste time clicking through trying to find questions that you may know the answer to. Or that might be weighted a little bit differently because there's only one question versus 4 questions. Go in order. If you find a question is a little bit out of your remit, it's a little bit more difficult, move on to the next question and perhaps come back at the end. Is there a place to flag the questions on there where you can flag and come back at the end? So you can do that as well. Obviously, the written's more straightforward because you've got the answer sheet, you've got the question booklet. So that's a little bit more straightforward in terms of how to navigate it because you've got all the questions in front of you. But for the computer, because you have to physically click to the next one, I think critical time's being used if you're trying to look for questions that have only got one sub-question to them. So I would recommend going in order, okay, and skipping past questions that you think, okay, no, this is going to require too much brain capacity at the moment, and I'm going to come back to that when I have done the majority of the exam. Data interpretation is your key to passing the exam, okay? The OSCE, I assure you, you are going to, if you listen to me and you follow me for the OSCE, you are going to pass. Now, obviously you have to put work in, it's not like, I'm just going to listen to this guy and I'm going to try and remember everything he says and I'm going to go and perform it on the exam day. No. And actually that Dublin, when I come to Dublin, that practice that you do with each other, and again, because I've been doing it since 26, when you come to Dublin and you practice amongst each other, and those that have come before will understand that, yes, my importance in giving the information to you is there, but your practice with amongst each other is what's going to get you through that part of the exam. Okay? So you can't disregard the OSCE because I'm telling you that you're more likely going to pass it. But I think a few days before your exam, a lot of the efforts should be put on perhaps data interpretation and ensuring that you've got that medical knowledge to get you through this part of the exam as well. Okay. So on exam day, please make sure, obviously, that you're going on time. That goes without saying. Okay, you will have a letter, an admission letter with your time, with your date, with your venue. You have to ensure that you arrive on time, because I believe any latecomers, and most OSCEs are the same, they won't let you in. So if you're traveling from Canada coming to Ireland, just give yourself enough days beforehand to make sure that you're as close to the venue as possible, particularly if you're traveling to Cork. If you're staying in Dublin, that's fine, because it's around the city centre. But if you're traveling to Cork, now I've never been to Cork, so I don't know where the exam is, but just make sure that you arrive there with plenty of time, okay? Or if you stay somewhere very close to the exam. They'll start off by doing your registration first. So I believe that you need to take your admission letter and a valid identification or your passport with you. Okay, without them, they will not admit you for the exam. So please make sure that you take those two things. Then they'll do your registration, which I believe lasts around 30 or 40 minutes. They'll give you your examination label. They will briefly talk to you about how the exam is going to unfold. And then you begin with, then obviously you begin your exam. You'll be there for around roughly 5.5 hours to 6 hours in total. Now, what to take? I'm often asked this question. The admission letter and valid passport is a must. Okay, that allows you admission into the exam. Now, a pen or a pencil, again, is probably a must, particularly if you're doing the data interpretation. Written paper, you should ideally take your own pen and pencil. They advise you to take your own watch, ideally like a digital watch with the seconds on there. And obviously you have to take your stethoscope with you. Any other practical elements, otoscopes, I don't know, monofilaments, whatever it may be that you need, that will all be provided in your exam for you. So you do not need to take any other equipment with you on the actual exam. And can you, in terms of in the cubicle, now obviously it's going to be different between Dublin and Cork, because in some exams they've had it in a hospital where it's a ward-based setting. So you have, for example, a bed with a curtain around there, and you move from one to the other. Whereas in other exam centres, for example, Dublin, particularly in the past, they've had cubicles where you go from one cubicle into another cubicle, like your traditional OSCE exam. Would you have a clock in there so that you can have a look at the timer and stuff like that? So obviously there's items that are prohibited to take. This is again obvious, but please don't take your phone. They won't let you. Yeah, don't take your phones in. Don't take iPads in. Textbooks. Don't do anything that will stop you from sitting the exam or that will disqualify you from the exam. Okay, there is a locker there. I think they call it a holding room with lockers in there where you can store your equipment or your bags or whatever else, your mobile phone. Keep your phone off, just turn it off completely and just keep it in the locker that will be provided, and then you'll get your stuff at the end. Okay, so don't take anything into the exam other than yourself, your stethoscope, and perhaps a pen. Nothing else. Okay. In terms of dress code, now this is important. Okay, dress, because your impression of you will count. Okay, now I'm not saying that you need to go in a 3-piece suit with a tie, waistcoat, blazer on. You don't need to go like you're going to your wedding. Yeah, but you have to go as if you're going to a clinical area in a hospital, which means that you look professional with a shirt, no tie. Okay, don't wear any ties on. Roll up your sleeves. Make sure your sleeves are below your elbows, particularly for the OSCE exam. Okay, just keep them, even if it's cold, roll them up. Okay, and just wear smart trousers and smart shoes on. Don't start wearing trainers on or flip-flops on, or anything, or hats on, caps on. Just try and be sensible when it comes to dress code as well. Okay, you have to look the part as well. Not only speak the part, but you have to look the part. Pass mark. Okay, now the pass mark is relatively easy to explain, okay? Because if you break the exam down into 3 parts, your practical skills, your communication skills, and your interpretation skills, you have a total of 120 marks for each skill. That's your maximum you can get. 120 for practical, 120 for communication, and 120 for interpretation skills. Within that, so each station itself will be marked out of 20. Okay, so for example, if you're doing history, that will give you 20. Suturing, 20. So 6 stations, 20, 120 marks maximum. Okay, now you need to achieve the minimum level of competence. This is important. They're not looking for you to get 100%. No one's going to get 100%. I wouldn't even get 100% if I did the exam. Okay, because of exam nerves, because of human errors, because of lapses in concentration, anxiety. There's many different reasons why you won't get full marks. Yeah, but you can do extremely well, but no one's ever going to get 100%. Yeah? But they're not looking for anywhere near 100%. You're looking for the minimum safe level of competence required as a junior doctor to work safely in the Irish healthcare system. And the marks for each one of them will be different. So practical skills will have its own pass mark. Communications, its own pass mark, and so on and so forth. Okay, so that's important. So you've got 3 elements, and where I find this exam a little bit more difficult is that you have to pass all 3 elements, which, if you think about it, you've got an OSCE exam. So you've got practical and communication skills that are together. Yeah, they're done on one exam. But yet you still have to break that down into 2, and you have to pass both practical and communication skills, and obviously interpretation skills to pass the exam. And that's where the difficulty lies, that you have to be consistent in your performance over all 3 types of skills that are tested. This statement that there's no compensation between interpretation skills, practical skills, and communication just reiterates the same point that I'm making to you, that you have to be consistent in your performance to pass the exam. Let's say that you scored 100% in practical skills and you scored 0 in interpretation. That's not going to transfer over to that to give you 50-50. No, that means you failed the exam. You have to pass all 3 to get through the exam. Okay, and that's what the last sentence says. To pass the level 3, candidates must pass, i.e. the minimum mark or above, each of the 3 types of skills: communication, interpretation, and practical skills. Now, this is just an example, okay, of the feedback that you'll get at the end once you get your results, okay? So if you see here on the left, you have your communication skills, you have your practical skills, and you have your interpretation skills, each with a maximum of 120 marks. Now, the standard set is here, okay? So 63.5, 74, 63. Okay? So you can see that there's a difference between the 3 different types of skills that are tested. You have to score above that. So it's not passing a set number of stations. You don't have to pass 3 out of the 6 to pass the exam. No, it's getting the adequate number of marks to pass the exam. And how I look at OSCEs is, you start the exam with 0. You start with 0. When you walk into station number 1, station number 1, you start with 0. And as you're moving forward between station 1 to 2 to 3 to 12, you're picking up marks as you go along by showing the examiner your skills, whether that's data gathering, whether that's examination, practical skills, communication skills. You're picking up marks as you go along. The more things you show the examiner, the more correct things you show the examiner, the more marks you get. Okay, and obviously, if you beat the 3 marks, then pass the exam. Okay, and the hope is that for all of you, and there should be no reason as to why all of you can't pass, okay, that you beat the mark in all of them. It's difficult because you have to pass all 3, but all I can reassure you is that you need to obviously not only just listen to me and practice amongst each other. You have to go into this exam with the belief and the confidence that you are going to pass. It's a very quick exam. Okay, if you approach the exam with any degree of negativity, anxiety, yes, everyone's anxious before an exam, But if you approach it with a sense of negativity, for example, you've done the exam in the past and you think, oh God, I have to do this all over again and there's a chance I might fail again. If you go in with that negativity, more than likely you're going to come out with a negative result. Okay, you have to go in with a high degree of confidence in this exam. Okay, even if you don't feel confident, you've paid an extremely large amount of money, not only for the exam, the course, the time, the effort, the whatever it is. You know, you've invested a lot in yourself, so you have to approach it with a degree of confidence. What would be the average minimum mark, Arena? That's what I've discussed on this slide. So roughly the numbers that you see here are around the numbers that you might get in the exam as sort of a standard setting of pass marks. They may be slightly higher. I've seen them lower. I've seen interpretation skills as low as in the 50s. Okay, I believe 58, 59 was the lowest. So if you think about it, if you see that out of 120, that's around 50, 60%. Okay, you should be getting that anyway to show that you are a safe, competent doctor. 50, 60% is not difficult. Now, this, and I'm going to elaborate this a little bit further when I come on to, you know, the next few slides. Okay. But why I've put this as important is because, particularly when it comes to the OSCE exam, if you do something that compromises patient safety, and this is normally in the emergency scenarios, okay, or in the practical skills. If you do something, for example, not disposing of the sharps into the box at the end, they fail you completely, and they will fail you. So let's say you're doing IV cannulation and you've explained the procedure beautifully, you've gathered all your relevant equipment, you've got the anatomical model, you're ready to cannulate, you've cannulated in, blood's come out, etc. You've done it all really well, but you've left the sharp next to the table. You failed that station. Or if you're doing a suturing station and you handle the needle, you touch the needle with your hands, you failed the station. Okay, so there are things that will be blunders or mistakes that will make you fail the station, and they are always to do with your own safety and patient safety. For example, the BLS station. If you don't confirm your own safety, the surroundings, the patient before you do anything, you're going to fail. Okay, so there are things that the exam will score you 0 on if you do them in the exam. And again, when I do the OSCE, I'm going to talk to you about the things to do, obviously, and the things that you should absolutely not do in each individual station. So common mistakes, and this is probably going to be the end of the discussion in terms of the overview of the exam. So common mistakes to avoid. Now I'm talking to you about the OSCE portion of the exam now. Okay, rote behavior. This means that you have simply learned a script. Okay, what you've done is, and a lot of people do this with PLAB 2. Okay, a lot of people do this with PLAB 2, that they've got a script, doctor, patient. Okay, and on that script, you've got doctor, patient with different sentences on there. And all you've done is you've learnt that script and you go to the exam and you regurgitate that script. So if something changes and the patient asks you something outside of that or gives you information that wasn't in your script, the examiner is not stupid. These are consultants. They know, they've done this exam many times before. Okay, they know those that have learned from a script and those that have not. Now that does not mean that you can't read a script, but you have to try and be adaptable and flexible with your data gathering, particularly when you're taking a history, when it comes to question taking, that you're adaptable in terms of what the responses the patient gives you. Okay, so rote behavior, behaving as if someone who's just learned a script, is something that they're going to know. Okay, now when you do clinical examinations and practical skills, rote behavior doesn't really play a role because you have to do the examination in one set format, so that's fine. you have to do a clinical skill in one set format. Again, that's okay. But when it comes to communication and history taking, you have to be a little bit more adaptable in terms of not so much relying on a script. Okay. When you're talking about stations that have ethical dilemmas attached to them, for example, contraception counseling in a young female under the age of 16, what the exam says is that if you use phrases like, can I ask you a personal question? Can I ask you, can I keep everything, I'll keep everything confidential. They say try and avoid these kind of phrases because you're the doctor. They should assume that everything will be kept confidential in that consultation anyway. If you find that a patient is finding it a little bit more difficult to open up to you, for example, if you're taking an alcohol history or you're doing anorexia history taking, then you can reassure the patient that things will be confidential, but you don't necessarily need to do that in every station. Everything will be kept confidential. Can I ask you personal questions? Just go ahead and start asking the questions. Okay. If you look at the fourth point, may I ask you some questions? Don't waste time. You have 7 minutes. 7 minutes for an OSCE is very short. Okay. You should introduce yourself, clarify the patient's identity, and move straight into the history. Okay. Don't say things or do things that will distract you or take time away from you because you don't have that time. You only have literally 5 minutes to data gather, and the questions will come from the examiner. Referring to the patient to the internet, particularly when you're doing counseling of surgical procedures, again, try and avoid this. You can always refer patient to a patient information leaflet, but don't try and refer patient to the internet for any reason for your exam. The final point on this, and I've taken this from the PRES 3 handbook, is the most important of all of these, not reading the station's instruction carefully. You don't have the luxury of time to afford to not read the instructions carefully. You have to read them meticulously with the time that's given to you. Okay? Read them from start to end, and some tasks may be lengthier than others. The good thing is that by the time you do your OSCE, you will know the tasks. You will know this is ABCD. This is history taking. This is community. You're going to know because I'm going to give you the stations. Okay. But at least read them first. Okay. And if you have any doubts, you're thinking, okay, I can't remember the name. I can't remember the task. I've gone all blank. Go inside. There's a copy of the task again. Before you approach the patient, tell the examiner, would it be okay if I read the task again? Examiner, read it and begin. In order to gain informed consent when taking history, do we need to explain that it involves asking questions about ABC? No, there is no consent for history taking. The patient has come to you with a clinical problem. You start to ask your questions regarding that. There is consent when you do an examination. There is consent when you do clinical procedure, but there's no consent for history and counseling. Always the first. Okay, any OSCE, you're always expected to ask the patient why they are there today. Okay, even if your task tells you abdominal pain, chest pain, diarrhea, constipation, etc., you always ask them why they are there. Okay, and then so for example, hello, my name's Karim. I'm one of the doctors working in the emergency department. Can I start off by clarifying your name and your date of birth, please? Nice to meet you. What would you like me to call you? Okay, what brings you in today? How can I help you? Okay, and then they'll tell you, I've got this pain in my tummy or pain in my chest, and then you move on with an open-ended question. For example, take me back to the beginning, tell me how it began, or tell me more about that problem. And then you give the patient a chance to talk, and then you close in with closed-ended questions to try and exclude or include differential diagnosis. Does that help? So common mistakes to avoid, continued. Okay, so the first one is don't bullshit. This is important because what I find is that, and I told you at the beginning, clinical management is the most difficult part of the transition from a healthcare system, for example, from Egypt or India or Africa to England or Ireland or America, because the management is so different. Okay. Now, when I say don't bullshit, what I mean is, if you don't know the management of a particular condition, don't try and make it up. What you can do is you can use knowledge that you already have from your own countries and see if that works here. But don't try and make things up. If you don't know the answer to a question, if the patient asks you a question and you have no idea about the answer, then it is reasonable to say to the patient that unfortunately I don't have that information, but what I'd like to do is check it for you or ask my senior and I will come back and I'll let you know this information. That's absolutely fine. You are a junior doctor at the level when you take this exam, and they understand that. You're not going to know everything. But when you have to do that too often, I'm going to ask my senior, I'm going to ask my senior, I'm going to ask my... If you're asking your senior everything, then unfortunately, you don't give the examiner any choice but to mark you down because you have no knowledge, okay? So clinical management is something that we will work on and that we will build together, okay? Offering analgesia is an important one. So there'll be many different types of history-taking stations where pain is the predominant complaint: chest, joint, abdominal, headache. And the patient might be in discomfort whilst you're taking a history. How you should approach this is you should tell the patient, first of all, I acknowledge that you're in pain. I'm sorry that you're in pain. Are you comfortable enough to continue? No simulated actor will say no. They have a script. They're following a script. Okay. None of them will say no and give me paracetamol. Okay. What they're doing, what they're looking for here in these pain scenarios when you initiate the consultation is, are you that type of doctor that gives pain relief without even knowing what the cause of the symptoms are? For example, if you're dealing with a headache and the diagnosis at the end is migraine, but at the beginning you gave paracetamol, what is paracetamol by itself going to do for a migrainous headache? So you assess first, but you acknowledge that they're in pain, you offer sympathy, and then you move on with your questioning. You don't offer them or give them analgesia until you've assessed, examined, come up with a diagnosis, and then given them the correct analgesia dependent on what you think the diagnosis is. Getting the name of the patient wrong. Now, this is easier. This is quite an easy mistake to make. You know, you've got 12 different stations, Mrs. Jones, Brown, Smith, Patrick, whatever their name is. You're going to get, you know, you're going to at some point think, I can't remember your name. Okay. And it happens to all of us. Okay. Even when a patient comes into, you know, my GP, you know, yeah, fine, I've got the name right in front of me, but so do you. You have the task in front of you. The name is on the task. Okay. Don't call them sir, madam, lord, you know, don't start giving them prefixes that they don't necessarily deserve or that they want. If you don't know the name, don't ask the patient 6 minutes in, I'm sorry, I forgot your name. Can you tell me your name? No. Have a quick look at the task. The name is there and you can always refer back to the name. Okay? So don't try and get the name wrong. Not knowing how to use a particular mannequin. There are going to be mannequins in your exam. There are going to be mannequins, whether that's fundoscopy, anatomical arms for cannulation, for venipuncture, for ECG machines. There's going to be a whole variety of different mannequins, EpiPens, peak flow meters, inhalers, lots of different things. I'm going to bring all this equipment to Ireland when I come. But you have to know how to use them, okay? And this is where your practice will become really important when I come to Dublin. Practicing with the equipment, touching the equipment, playing around with it, using it, that will really help. Okay. And again, for those that have come, will understand the importance of practicing using the equipment before you go in the exam. Problems with psychiatric stations. So every single exam, one active station will be psychiatry. Guaranteed. Okay? Whether that's And for the most part, it's history taking. So acute psychosis, auditory hallucinations, depression, anxiety. What else? Symptoms of mania, whatever it may be. There will be some psychiatric station that you have to do in the exam. And knowing how to take a good psychiatric history is going to help you get through. If you look at psychiatry, I've done a lot of psychiatry in my time. Psychiatry, when you take a history and when you assess someone's mental status, it takes a long time. Okay, it takes at least an hour, maybe even longer. You have 6 minutes, 5 minutes. I would say 5 minutes to take a psychiatric history. No examiner in the world will expect you to be able to do a psychiatric history in 7 minutes. It's not possible. So what they'll do is they'll mark you on what you have done, the professionalism that you show. So for example, if someone's acutely psychotic and they're looking around the room and they're telling you, doctor, I can hear voices, how do you reassure them that they're in a safe place, that you're the doctor looking after them, that they're not in any danger, and you're here to ask them a few questions to try and figure out how to help them best? Okay, so dealing with psychiatric stations is another, I wouldn't say a mistake, but something that you have to work on to be able to get through the communication skills of the exam. And lack of basic knowledge, well, that's going to reflect your performance on all elements of the exam, from interpretation skills through to communication skills and obviously practical skills. You have to have that basic knowledge of medicine to be able to get you through. All of you have that. You're all doctors. You know, I'm not here to teach you how to be a doctor. You are already doctors. But I'm here to teach you how to show the examiner that you are the safest doctor and a safe doctor to be able to practice in the system that you're coming into, and that I will give you. Okay? A few other mistakes, and I think this, I'm going to wrap this up now. Okay? A few other mistakes. So not behaving as you would in real life. This is really important. Okay, don't. And again, this is easier said than done. I've done many exams. Okay, right the way through. I've done PLAB, I've done USMLE, I've done all the GP exams, I've done MRCP, I've done so many different exams. Not behaving as you would in real life is going to be the thing in the OSCE that fails you. If you're trying to act your way through, you're not going to score well. They're looking for realism from you, real empathy. Okay, real emotions, real communication skills. So behave as you would if this was a normal clinic, if you were in A&E or obstetrics and gynecology, etc. Behave as you would in real life. Offering chaperones. So this is really important. Okay, offering chaperones in clinical examinations or practical skills is going to be a big part of the introduction to any station. Okay, if you're a man examining a female, an intimate part of their body. So for example, a respiratory exam, cardiovascular exam, you're going to do an ECG on them, always have a chaperone present. But there are some stations in which a chaperone is mandatory. Catheterization, testicular exam, breast exam, rectal exam, okay, bimanual exam, speculum. Those are mandatory chaperones. Lack of empathy, we'll talk about this more when we talk about communication skills, when we do that course. Again, poor behavior, just try and maintain an air of professionalism around you. Poor examination technique, again, this will be improved when I show you A, how to do them, and B, when you practice them. Okay. Oversimplifying names of body parts. So this again comes down to communication skills. Can you use medical jargon when you communicate with the patient? The answer is yes, you can. As long as you explain the medical jargon or the term completely so that the patient understands, that's fine. Okay. The scattergun approach or the illogical haphazard approach, this is more to do with when you're taking a history, for example, if your questioning is all over the place, Or when you're examining someone, you're going from the feet to the chest to the eyes to the hands, and there's no logical approach to what you're taking. You're going to fail. Not finishing the station, we've talked about this. Really, the only station that you don't need to finish within the time that's being given to you is communication. All of the other ones you should finish within the time frame. Okay? And then staying in the station after the time is up. Please don't do this. Okay? Once your bell goes off, that it's time for you to move on to the next station, don't start speaking and throwing out random things and throwing out antibiotic names and salbutamol. As you're leaving the door, you're shouting the dose of salbutamol. Just leave. Concentrate on your next task. Okay? And once you finish the station, please forget completely about the previous task. If you take the last task in with you to the next one, I promise you it's going to have a domino effect in your exam. You've got to block out station 1 when you move on to station 2, and so on and so forth. Forget about them. You can't change them. Okay? You can't go back and tell the examiner, change what you wrote. I'm going to tell you the amount. You